Good afternoon, class. Today we're going to talk about antibiotics part 2, and we're going to start off with talking about multi-drug resistant organisms. And these organisms are very familiar to some of you, or will be at least. And also research indicates that antibiotics in one class may affect the resistance in another class of antibiotics. So these multi-drug resistant organisms, the first one is MRSA, which is your methicillin resistant Staph aureus. We no longer use methicillin. We use oxacillin in order to determine the resistance. Your other next one is your VREs, which is your vancomycin resistant Enterococcus, and we usually see these in UTIs. And then your ESBLs are your extended spectrum beta lactamases, and we use carbaminogens for this. Now ESBLs are gram-negative bacteria that produce an enzyme, your beta lactamase, that has the ability to break down commonly used antibiotics such as penicillins and cephalosporins and render them ineffective for treatment. Now, if the ESBL producing bacteria causes an infection, a different antibiotic may need to be used in order to treat the infection. People who carry ESBL producing bacteria causing an infection without any signs or symptoms of an infection are said to be colonized. The most common ESBL producing bacteria are some strands of your E. coli and your Klebsiella pneumoniae. And then your last of these drug-resistant, multi-drug resistant organisms is going to be your CREs, and those are your carbaminogens resistant Enterobacteriaceae. This is a major health problem. It is currently the world top health problem. When infections occur, like mentioned before, we need to place the patient on contact isolation, and with proper hand washing is the number one thing that you can do in order to prevent these infections from spreading. Okay, so we're going to start off with your aminoglycosides. And before we get started with this bacteria, with this antibiotic class, I want to go over some things. And so the first thing I want to go over is the post-antibiotic effect, or your PAE. And this is defined as a persistent suppression of bacterial growth after a brief exposure, meaning anywhere between 1 to 2 hours, of a bacteria to an antibiotic, even in the absence of a host defense mechanism. And this is important when you're looking at your classes in order to determine their effectiveness. The other thing is that increased levels of antibiotic will equal increased risk of nephron and ototoxicity. So we want to keep that in mind when we're giving our antibiotics. So troughs are going to be monitored initially, and then every 5 to 7 days until the drug is discontinued. Creatinine levels are going to get checked every 3 days. Peaks are going to be drawn 30 minutes after a 30-minute infusion, which means 1 hour after the start of the infusion, or 30 minutes after an IM injection. And remember that when we are talking about your beta lactams, they are time-dependent killing antibiotics, so they do require a minimum concentration in the blood for a specific amount of time in order for them to be effective. So now we're going to get to your aminoglycosides, and dosing is going to depend on the bacteria that we are trying to eradicate. So this aminoglycosides, they are bactericidal, meaning that they kill the bacteria. They do have a minimum inhibitory concentration, so they do need a certain concentration in the blood in order to kill the bacteria. Uses are going to be bacteria such as aerobic gram-negative bacilli, such as E. coli, Klebsiella pneumoniae, Proteus, Mirabilis, and Pseudomonas argounius, so on. And so those are all different types of bacteria that this aminoglycosides will be effective for. Your amikacin, your gentamicin, your tobramycin, your neomycin, streptomycin, paromomycin are all antibiotics in this class. Others are going to be your neomycin, which is a PO version. It does suppress the normal flora of the GI tract, so it's used to prep for any colorectal surgery. It can be given topical for infections of the eye, the ear, or the skin. Amikacin is reserved for any of your resistant infections. Tobramycin is given for recurrent pulmonary infections such as tuberculosis, severe uncommon infections as well. And your pyromomycin, also a PO antibiotic, and it's for intestinal amoebiasis and tapeworm infections. And those are what we would use pyromomycins for. They usually are given with a beta-lactam. They do have a post-antibiotic effect, meaning that they do continued growth suppression with exposure of the antibiotic. Treatment, again, we treat these for virulent infections. They do have a narrow therapeutic range, however, the max efficacy, minimal risk of toxicity. Trough levels, again, drawn just prior to the next dose, and peak levels only with TID dosing. So we only need to do peak levels with this class when we're giving this class 3 times a day, because it is believed that peak levels are short-lived. And that would be one of the reasons why we don't do them for this class. Okay, so continuing with aminoglycosides, their adverse effects, this limits their use. So we watch out for nephrotoxicity, which can cause CAS, proteinuria, increased BUN and creatinine. The results in acute tubular necrosis. Nursing care, where you want to make sure you're monitoring eyes and nose, BUN and creatinine levels. It can cause ototoxicity, can cause cochlear damage, vestibular damage, hearing loss, or loss of balance. It could have a hypersensitivity reaction, so you may have paresthesia, pruritus, rash in your hands and feet. Overgrowth of non-susceptible organisms, opportunistic or super infections. You want to watch out for neuromuscular paralysis as well. It can be rare. It is reversible. It does result in respiratory depression or muscle weakness. And then your streptomycin only, for streptomycin only, it may cause a neurologic disorder called peripheral neuropathy. It can also have optic nerve dysfunction, and in addition, peripheral neuropathy, it's also known as neuritis, and it results of damage to your peripheral nerves, often causes weakness, numbness, and pain, usually in your hands and feet. It can also affect other areas of your body as well. Also important to know with aminoglycosides, risk for toxicity is greatest in specific patients. These patients are going to be those that have already renal impairment, so you do need to check your labs and your urine output. It may have already be receiving nephrotoxic or ototoxic drugs, so you need to check their med history. And those patients that are receiving high dose or prolonged therapy of aminoglycosides also are at greater risk for toxicity. Okay, so continuing on with interactions, aminoglycosides with our penicillins inactivates the aminoglycosides. So if they're given in the same IV, penicillin will inactivate the aminoglycosides, so we can't give those together. Aminoglycosides also interact with loop diuretics, which increases their risk for ototoxicity. They interact with warfarin. It will increase the anticoagulation, so antibiotics kill the bacteria in the GI tract, which decreases in vitamin K procedure. It decreases the vitamin K produced. Neuromuscular blocking agents, prolonged duration of action. So it's it acts like a paralytic, like acts like a paralytic. So you have the agents like rocuronium, and succinylcholine. Those are all part of this neuroblocking and neuromuscular blocking agents. Other contraindications, now not just interactions, but other contraindications. Patients with renal immaturity, like neonates, increased risk of toxicity, so the med will build up and will leave increased risk for toxicity. You want to be cautious with patients with kidney impairment, hearing loss, and myasthenia gravis. And just as an aside, myasthenia gravis is a chronic autoimmune neuromuscular disease that causes weakness in the skeletal muscles, which are responsible for breathing and moving parts of your body, including your arms and your legs. So you want to be cautious with giving this to those patients that have myasthenia gravis. You also want to be cautious with patients already taking nephrotoxic or ototoxic drugs, and also contraindications for aminoglycosides are going to be pregnancy or your breastfeeding moms, irreversible bilateral congenital deafness is distributed in the breast milk. So these are meds that we do not give to our pregnant patients. Okay, so as we continue, your nursing considerations for this class of aminoglycosides. Again, you want to monitor for signs and symptoms of ototoxicity. You want to monitor the eyes and nose, the BUN, the creatinine. Again, signs and symptoms of nephrotoxicity. You want to monitor for hypersensitivity reactions, any type of pre-existing health conditions, either neuro or renal. Baseline, you want to have a baseline neural function assessment. You want to know what their hearing tests are or vestibular function is, how well they can keep their balance. You want to know what their hydration status is. So again, you want to encourage fluids to help prevent the nephrotoxicity. You want to look up their labs and make sure that their renal function tests are being evaluated while they're on these antibiotics. If they have a higher risk for toxicity, you want to see what other nephrotoxic or ototoxic meds they're on, or any other neuromuscular blocking agents that they may be on. Meds like cyclosporin or IV contrast are going to fall into this area here. Neonates or older adults may have impaired renal function, and especially if they're on long-term therapy or higher doses, you need to watch out for and monitor those patients. Octic drops or topicals, again, you want to assess for any redness or burning or itching in the areas that it's being applied. If it's been given IM, you want to check for the duration. For the induration, it may be producing or may be forming a hardened mass under that muscle, like for example gentamicin IM. You want to be able to give it deep and slow into a very large muscle like the ventral gluteal, which will help to prevent this hardened mass. And also other considerations you need to look into is check your IV sites, check the site for heat, swelling, redness, pain, red streaking over the vein. All of these, because we're giving these meds IV, you want to check for incompatibilities such as penicillin. You want to make sure you're only diluting the antibiotic with normal saline or D5W. You want to make sure that the solution should be clear or slightly yellow, and you want to infuse it at the correct rate. That's going to be very important, especially with these drugs that are such high risk for toxicity. Okay, so we continue on with the aminoglycosides. Now we're reaching patient teaching. Again, you want to make sure that you're teaching your patient. You want to educate them for hearing loss, report what changes they need to report in their hearing, or any symptoms or signs of fullness in their ear, any nausea or vomiting, etc. Those things are going to be things that you want to educate your patients to be able to be aware of, so they can let their physician know. You want to have them increase in fluids up to 3 liters per day, unless it's contraindicated for any other medical condition. This will help to decrease their risk of neurotoxicity. You want to educate regarding super infections, so you want to make sure that they take in yogurt or buttermilk or probiotics, which will help to kind of prevent these meds from leaving them susceptible to super infections. You want them to report any changes, again, in hearing, ringing in the ears, fullness in the ears, nausea, vomiting with motion, ataxia, nystagmus, any dizziness, all the signs of ototoxicity we might see. Ataxia, again, it's a lack of muscle coordination. Nystagmus is involuntary eye movement, so you want to make sure you're looking at those. Eye drops, you want to have them report any redness or burning or itching. You want them to report to their physician as well any hematuria, blood in the urine, or any cloudy urine. These are going to be signs of nephrotoxicity. And always educate your purpose and your reasoning for getting the antibiotic or getting the drug. It's also going to be very important. Okay, so we're going to start with quinolones. These are your fluoroquinolones. I want to also address that when we talk about parenteral, we mean the drug administration means that it's any type of non-oral means of administration, but it is generally interpreted as relating to injecting directly into the body, bypassing the skin and mucous membranes. So your quinolones are broad spectrum. They're gram-positive and gram-negative. You have in this class norofloxacin, ciprofloxacin, levofloxacin, moxifloxacin, orfloxacin. Ciprofloxacin is your drug of choice for anthrax. These are, again, bactericidal, and quinolones are very potent bactericidal. Uses for these antibiotics are going to be UTIs, upper respiratory infections, GI infections, infections of the bones or joints, skin infections, soft tissue infections, and as mentioned before, anthrax. It is prevention of anthrax in those that have inhaled the spores. We commonly use these as alternative to parenteral antibiotics for severe injections. Patients on IV antibiotics can go home on these PO meds, and adverse effects of these, again, GI discomfort, nausea, vomiting, diarrhea. So you want to educate them to take the medications with milk or meals. Also, they can have super infection. So we talk about super infections again: yeast, thrush, C. diff. You want to make sure we're looking for those. These may be adverse effects of these quinolones. It can affect the central nervous system, so our patients can complain of dizziness, headache, restlessness, or confusion. It can cause phototoxicity, so again, you want to educate your patients to avoid the sunlight, use sunscreen, protective clothing when they're out in the sun. The black box warning for quinolones is, again, increased risk of tendinitis, Achilles tendon rupture. So again, you want to educate your patients to report any pain or swelling, redness at the Achilles site. You want to make sure they stop taking the medication and avoid any exercise until this redness or pain subsides. And this is one of the black box warnings for quinolones. Okay, so we're continuing on. Interactions with your quinolones. It's going to interact with ciprofloxacin. Remember, decreased absorption is going to cause decreased absorption if you give it with ciprofloxacin. Antacids, dairy products, calcium, magnesium, iron, zinc, and sulforaphate. Administer these 6 hours before or 2 hours after Cipro, so it doesn't cause the decreased absorption. Your potential oral anticoagulants, so increased anticoagulant activity. It can cause increased anticoagulant activity, so you want to monitor your PTs and your INRs. Contraindications are going to be prepubescent children due to the risk of Achilles tendon rupture, except in the treatment of E. coli. So yes, we just have to be extra careful with these prepubescent children when giving it, if we're giving it for E. coli. If not, then we don't give it to them because of the Achilles tendon rupture risk. Nursing considerations that you need to remember, again, IV ciprofloxacin. You want to give large vein, diluted, make sure you're giving it over 60 minutes. Use a separate line from other IV fluids or other IV antibiotics. And monitor for drug interactions. So with antacids, iron, zinc, sulforaphate, oral anticoagulants, you want to monitor for those interactions. So again, patient teaching. You want to make sure you instruct these patients not to take antacids, iron, zinc, any multivitamins, sulforaphate, with the quinolone. So you want to make sure that they take it within 2 hours of taking the quinolone. So so that they have a better effect. Educate them, again, wear sunscreen, sunglasses, avoid the sun if possible because of the phototoxicity. Phototoxicity is also called photoirritation, and it is a chemically induced skin irritation that's requiring light that does not involve the immune system. It is a type of photosensitivity. The skin response resembles an exaggerated sunburn. You want to also make sure you're teaching them about any headaches or dizziness, restlessness, diarrhea, vomiting, oral candidiasis, flushing of the face, inflammation of the tendons, especially this because of the Achilles tendon rupture. Signs and symptoms of superinfection, also important for them to know. These are symptoms of that, so you want to make sure that you're educating your patients about these things. You want to check with the prescriber before taking any over-the-counter medications, because many do have drug reactions with the quinolones. And again, take exactly as ordered and make sure you're taking them for the entire course that is required. Well, then now we're going to start with clindamycin. Again, clindamycin can be bactericidal or bacteriostatic, depending on the concentration that we give it. We use this to treat any bone, GU, tract, intra-abdominal, anaerobic pneumonia, sepsis types of infection. They can have an adverse effects and would be nausea, vomiting, abdominal pain, anorexia, diarrhea. It can cause C. diff or neuromuscular blocking properties, such as may enhance neuromuscular drugs. C. diff, again, pseudomembranous colitis, and necrotizing inflammation of bowel condition. So you do want to make sure you're looking for these adverse effects if these patients are on clindamycin. Interactions, clindamycin interact. It will enhance the effects of the neuromuscular blocking drugs, and that's important for you guys to know. And again, contraindications for giving clindamycin: ulcerative colitis or enteritis because of the potential for C. diff, and children less than 1 month of age. Nursing considerations with clindamycin: you want to, again, it's going to be age, baseline GI assessment. So you want to make sure you're any existing GI disorders or colitis due to that risk for C. diff, and also nursing considerations, taking any neuromuscular blocking drugs. Again, concurrent use can increase the neuromuscular blocking and respiratory paralysis. Administration: Clinda can be given PO with 8 ounces of fluid. It can be given IM. You want to use a deep, large muscle mass in order to give it. It can be given IV piggyback. You never want to give it IV push. It's too rapid of infusions. It can cause severe hypotension and potentially a cardiac arrest. You want to use the guidelines provided in order to know how to dilute it. Patient in teaching, important, you want to make sure you're, again, taking PO with at least 8 ounces of water or fluid. Topically, don't use near the eyes or any broken skin. If it gets in your eyes, flush with lots of tap water. Don't use with any peeling, abrasive acne products, any soaps or alcohol containing cosmetics. And then if you are giving it vaginally, do not have sex while you're taking the medication. Next medication that we're going to talk about is your colistimethate, and it's the only antibiotic to treat the CRE, which is your carbapenem resistant enterococci. This cholistomethate is again used to treat CRE. Was previously not used because of the toxicity risk, but this one is the only one that we actually have to use to treat CRE. It can be given IV, IM, by inhalation. Adverse effects for this med, again, renal failure, acute respiratory failure if it's given via inhalation, and neurotoxic effects, so signs and symptoms of paresthesia, numbness, tingling, vertigo, dizziness, and speech impairment. Those would all be any types of adverse effects. Contraindications: pregnancy, we do not give this with patients that are pregnant. It does cross the placenta, so it will affect the baby. Nursing considerations, again, you want a baseline assessment for neuro, respiratory, and renal function. If we're giving it by inhalation, we need a baseline assessment. You do want to infuse the medication over 3 to 5 minutes. And important patient teaching with this med is, again, to report any numbness, tingling, vertigo, dizziness, or problems with speech. Next med is your daptomycin. Again, this is only given via injection. We use it to treat complicated skin and soft tissue infections, MRSA and VREs. Adverse effects are usually fewer than 5%. Hypo or hypertension can cause headaches or dizziness, can have rash, GI discomfort, increased liver enzymes, local injection site reaction or renal failure, dyspnea, and fungal infections. Interactions, increased risk of myopathy when it's given with any statin medication. Statins are your meds that you give for your cholesterol. And nursing considerations, again, you want to check vital signs, and you want continuous monitoring of blood pressures because of the possible adverse effect of hypo or hypertension. Next med is your linezolid. Linezolid is developed to treat VRE, also healthcare associated pneumonia, any complicated skin and skin structural infections, including MRSA. It can be given PO or injectable. Adverse effects are going to be headaches, nausea, vomiting, diarrhea. Interactions that you need to look for: strengthens vasopressor drugs, so dopamine being an example of that. Serotonin syndrome. It can cause serotonin syndrome when it's used with SSRIs. SSRIs should be stopped prior to starting treatment with the linezolid. Tyramine containing foods can cause an increase in blood pressure. So examples would be aged cheese or wine, soy sauce, smoked meats or fish or sauerkraut, and are all examples of tyramine containing foods which can have an interaction with the linezolid. Contraindications, so these mostly are used with caution. They're not complete contraindications. Again, foods containing tyramine and vasopressors and SSRIs. Continuing with linezolid, nursing considerations, again, ask about home meds, especially if you're taking any SSRIs. Intake of tyramine containing foods, so what their diet is. Administering Administration with this medication, again, it can be given PO. You want to give it with food or milk. IV, you want to protect the medication from light. You want to infuse it over 30 to 120 minutes. And you do not want to mix with other meds. Patient teaching, you want to avoid, again, tyramine-containing foods while taking this medication. So again, any aged cheese or wine, soy sauce, smoked fish or meat, and sauerkraut. You want to report any severe abdominal pain, any fever, severe diarrhea, any worsening of signs and symptoms of infection. And again, important to teach your patients to continue their therapy for the full length of time. Alright, so we're going to continue with metronidazole. We use this to treat intra-abdominal or gynecological infections, any protozoal infections, colitis, adverse effects, dizziness, headaches, GI discomforts, nasal congestion. The reversible effects are neutropenia and thrombocytopenia. If it causes this, it will be reversible once you stop taking the medication. Interactions, alcohol intolerance. So important to know with metronidazole is that alcohol intolerance is acute. You must avoid alcohol for 24 hours before and 36 hours after taking this medication, or else it can cause severe abdominal distress. May increase toxicity of lithium, benzodiazepines, cyclosporin, calcium channel blockers, various antidepressants, and warfarin. Also, other interactions, phenytoin and phenobarbital decrease the effects of metronidazole, so that's important to know as well. Other contraindications completely is first trimester of pregnancy, so patients in their first trimester cannot have metronidazole. Other nursing considerations, again, assess for contraindications, especially the first trimester of pregnancy. It's also very important to remember. Review your signs, your culture sensitivity report, and you always have a baseline assessment. So you want to do a neuro assessment. So you want to note any dizziness or numbness, tingling, motor abnormalities. You want to have a GI assessment, noting for any bowel sounds, patterns or problems, and GU, urinary patterns, color, eyes and nose. All baseline assessments need to be done. Again, alcohol intake, it does cause acute alcohol intolerance, so you want to make sure if they're taking alcohol on a regular basis that this is not a medication that we give them. Drug interactions, so benzodiazepines, calcium channel blockers, various antidepressants, and warfarin have all been found to have some type of drug interaction with your metronidazole. Topically, if we give it, you want to make sure you're wearing gloves to prevent undue exposure to the medication. Patient teaching, again, avoid alcohol, including any over-the-counter cough medicines, because they all contain alcohol. You want to administer intravaginally. If we do that, we want to do it at bedtime. It's a lot easier, keeps the medication in the vagina. You want to take it with food to help to decrease the GI upset. It is kind of harsh on your stomach. And you want to educate the patient for the purpose and the reason of the drug so that you can obtain better compliance. Alright, so we're going to continue on with nitrofurantoin. This is a medication that is given PO only. It is primarily used for UTI. Adverse effects are GI discomfort, dizziness, headaches, skin reactions. It can cause blood dyscrasias or ECG changes. Blood dyscrasias is just another word for blood disorders. Can have peripheral neuropathy, possibly irreversible, and hepatotoxicity. It is rare and it does happen. It's often fatal. Interactions, probenecid, it's a uric acid reducer, will reduce renal excretion, and other interactions again with antacids. It does decrease the absorption of the medication. Contraindications for nitrofurantoin is significant renal dysfunction. Drug concentration in the urine will be elevated. Nursing considerations that we need to remember: any drug allergies, specifically to nitrofurantoin, renal and liver function. You want to have a baseline sensory, motor, and skin. So when we're looking for any potential for peripheral neuropathy, continuous monitoring of hepatotoxicity, peripheral neuropathy, and superinfection. So those opportunistic infections are going to be important to look for. Signs and symptoms of hepatotoxicity, like jaundice, itching, rash, hepatomegaly, and also signs and symptoms of peripheral neuropathy, like numbness or tingling. Administration of this med, again, it's PO. It's given with plenty of fluids, food, or milk. You don't want to crush the tablets. It can cause GI upset or stained teeth. Patient teaching, that's important. Again, you want to have them report any abdominal cramping, dizziness, severe skin reactions, or jaundice. Okay, so as we continue, we're going to talk about quinapristine and dalfopristine. They are together. They have a synercid reaction. Together, these two meds equal synercid, which is the name of the antibiotic. They're two streptogramin antibacterials. They're given IV. It's a specific IV treatment for VRE and MRSA. Adverse effects are going to include arthralgias or myalgias, like muscle pain or joint pain, which may become severe at times. Infusion site may have pain, inflammation, edema, or thrombophlebitis, which is a blood clot that causes inflammation and pain. So you want to look for that. Interactions, cyclosporin, increased levels of the quinapristine or dalfopristine must be flushed with only D5W, no saline or heparin flushes. Okay, so other nursing considerations, again, vital signs, superinfections. We want to make sure we're looking at that. You want to monitor for muscle aches and pains because of the potential for the arthralgia and the myalgia and the myalgias. Again, administration must be infused with only D5W. You don't want to use any normal saline or heparin flushes. You need to make sure you IV constitute with only D5W. You don't want to shake. You just want to gently swirl. And you want to give over 1 hour. Okay, so as we continue, we want to talk about vancomycin. Vancomycin is bactericidal. It will kill the bacteria. It's the antibiotic of choice for MRSA. It can be given PO. And PO, it's indicated for C. diff or the enterocolitis. If we give it IV, it can be for bone and joint infections or sepsis. Vanco has a very narrow therapeutic range, so they need to draw peaks and troughs. Adverse effects, important ototoxicity, like again I said, it can be rare and reversible, so you need to educate your patient to make sure they notify the physician of any changes in hearing. Nephrotoxicity, kidney damage, again, so nursing wise you want to monitor eyes and nose, urine output, renal function tests, and your Vanco trough levels. Red man syndrome, also important. It can occur when we give it too quickly, so with rapid infusion it is more at risk. It will cause rash, flushing, tachycardia, and hypotension. So for nursing, For administration, it's very important to make sure you're giving it for over an hour. Hypotension, another adverse effect, if we give it with rapid infusion as well. And again, the considerations that you need to consider is to administer over 1 hour. Thrombophlebitis, another adverse effect. Pain at the injection site. Nursing wise, you want to make sure you're monitoring the injection site for redness, swelling, inflammation. You want to rotate the injection sites if at all possible, so that way you don't keep using the same site. Interactions, other nephrotoxic drugs, so aminoglycosides, cyclosporins, IV contrasts, other interactions like other ototoxic drugs as well, so loop diuretics, aminoglycosides. So nursing wise, we need to make sure we're monitoring the patient's hearing. Addictive effect of neuromuscular blocking agents also is something that we need to look into and have consider as an interaction. Contraindications, any allergy to corn or corn products, and we need to give with caution for patients that have renal dysfunction or hearing loss already. Other nursing considerations we need to remember, again, other nephrotoxic or ototoxic meds, baseline and monitor for hearing status, skin assessment, renal status. You want to monitor their vital signs, especially their blood pressures, trough levels. So after blood has reached this steady state, you want to make sure you're maintaining those trough levels. And again, you want to encourage fluids at the minimum 2 liters per day. Administration-wise, for vancomycin IV, must be infused over at least 1 hour. So that you want to prevent hypotension, red man syndrome. You want to monitor those sites frequently, so it may cause extravasation. Lab work, you want to monitor those trough levels, so immediately before the next dose you want to see what those trough levels are, especially during the prior to the second or the fourth dose. Patient teaching wise, so make sure that patients are drinking lots of fluids, at least 2 liters every day, which will help to decrease the risk of the nephrotoxicity. You want to have them know to report any changes in hearing, nausea, vomiting, any unsteady gait, any dizziness, generalized tingling, chills, fever, rashes, or hives. You want to stress the importance of following up appointments with the patients, again, to monitor those serum levels. And you want them to know to make sure that they're taking exactly as prescribed for the entire course. Key points that we need to remember with all of these meds is multi-drug resistance is a significant health issue. Aminoglycosides, potentially serious toxicities. Quinolones are very potent bactericidal broad-spectrum antibiotics. Linezolid is a treatment infections such as associated with VRE. Metronidazole, we use it to treat intra-abdominal or gynecologic infections. Nitrofurantoin, primarily we use it for UTIs. Your quinopristine and dalfopristine is used for sepsis or life-threatening VRE. Telebacin, which is new, is used to treat MRSA. It is a derivative of the vancomycin. And then antibiotic therapy, nursing considerations important. Obtain allergy and hypersensitivity history. What was their reaction? Always explain your purpose and reason for the drug. It will help to increase compliance. And superinfections can occur in the mouth, the respiratory tract, the GI and the GU tract, and on the skin. So you want to monitor for these and educate the patient regarding these so that we know, so that they know when to report any of these symptoms. So again, I know this is a lot of information. Make sure you follow the PowerPoint. Make sure you follow the information that's on the PowerPoint, so that way you can follow up and for your drug charts. And this is the information that you should use for your drug charts as well. All right, thank you very much. We'll see you next week.